So what's the challenge in dermatology with the recognition of antibiotic resistance? Why should we care? I'm treating acne and I'm using antibiotics. I don't see resistance problems. You know, maybe P. acnes resistance, they get a little less effective. I switch to something else or I do something different. But it's not something we're testing for, and we're not considering the collateral damage that when we're treating acne and we give an antibiotic, whether it be topical or oral, other microorganisms are affected and they develop resistance, and then they're transferred to other people, and who knows what happens. We're not seeing that in our practice. But it's hard to find data to see what that consequence is. There's a little bit, but Ted and I talk about this. We need more information. So what's the response, number one, from dermatology practitioners that I hear? This applies to drugs that are in the hospital. We don't treat these infections or organisms. So if dermatologists are using too many antibiotics per year, causing resistance problems, how come doxycycline and minocycline are still effective for most cases of MRSA? I don't see problems with resistance. The fact of the matter is, when you're looking at MRSA infections, Staphylococcus aureus, first of all, is not part of the normal flora in the majority of people. There are people that are commonly carriers. But when you utilize doxycycline and minocycline, you have to remember that over time, with tetracycline agents, Staphylococcus has had difficulty in developing resistance to that particular class of antibiotics. It's been much easier with penicillins and extremely easy with cephalosporins based on the mechanisms involved. So yes, we are seeing increased resistance with doxycycline and minocycline with Staphylococcus aureus, but the fact that we've utilized it a lot in the community doesn't mean that we're not seeing resistance problems related to those antibiotics with other microorganisms. So the pathogens representing a threat, this was something that George Zanel shared with me back in 2013. So this is what the CDC had on its urgent list. C. difficile, Enterobacteriaceae that are resistant to carbapenem, not something that's going to trigger, oh, gee, I need to worry about that in most cases. Serious, methicillin-resistant Staph aureus does hit home, okay? They're not only talking about hospital-based cases, they're talking about cases in the community, and Ted's going to give you an excellent update on that. Erythromycin-resistant Group A Streptococcus and clindamycin-resistant Group B Streptococcus. That hits home because we may be selecting organisms of streptococci that are pathogens, not necessarily for skin disease in many cases, though they can cause cellulitis or folliculitis, but on transfer to someone else, leading to some type of infection like an upper respiratory infection. We really have no way to track that, but we know that the resistant organisms are happening. And then other things that we're aware of in the literature, we've known for years that we put patients on chronic antibiotic therapy, and we select out a certain number of patients that have gram-negative bacteria in the anterior nares, or maybe have gram-negative folliculitis. There are probably more cases of that than we really think, because we expect these patients to have a bunch of pustules, especially around the nares, but they don't all necessarily have that. And unless you look for it, you're not going to find it. So there's probably more cases of that than we identify, but I don't know that it's a pandemonium, but we know that it can occur. Okay? We also know that if you expose patients to topical oral antibiotics or in combination, that they will select out a higher concentration of Group A beta hemolytic strep in the nasopharynx. And more of them are going to be resistant to the antibiotics that were used, and you'll also see colonization of the nares. And with topical agents, you'll see colonization in areas where the drug is not even being applied. So we have to recognize that those things can happen. What's the significance? We'll talk about that a little bit more, but we have to understand that that is happening in the patients. So this is just some examples from data when erythromycin was being developed, and it also would apply to clindamycin if it's being applied alone to the skin compared to a vehicle. And you'll see that the staphylococci on the face that are part of the normal flora are higher than in the group using the vehicle. And then you'll see the same thing on the back, even though it's not being applied on the back, it's only being applied on the face, because people touch themselves in different areas and they transfer, just the same way as they can transfer to someone else. in the nares. Okay, so they're going to colonize in the nares. Now, Staph aureus in the nares also increased. Not always statistically significant at every time point, but the increases were there. And this is simply by applying topical erythromycin to the skin. And so we need to be aware of that possibility. And then P. acnes we know is going to become resistant, but the point is, it's not only the only bacterium there. This is basically saying what I said earlier about the oropharyngeal colonization in patients that were on antibiotics for at least a period of 3 months versus those that were not. And they were on a variety of different antibiotics, sometimes alone, sometimes in combination with a topical, and not necessarily on anything else other than the antibiotics. And when they followed these patients out, they saw a higher rate of colonization of group A beta hemolytic strep pyogenes, in the group that was on the antibiotics and the group that was not, that's in the oropharyngeal area. Okay? Now, this is another thing that came up, was the association with upper respiratory tract infections. Now, this was problematic in the sense that they utilized a database from the UK, which is essentially a giant health maintenance organization where they have data on thousands and thousands of people. So it was not a prospective study where the patients were being examined and they were diagnosing and culturing the upper respiratory tract infections. They went backwards in the database and they compared it to people that were not on antibiotics, and they compared it with urinary tract infections versus upper respiratory tract infections as a control. And you can see the majority of the people were on oral and topical antibiotics. So you're looking at almost 120,000 people with acne on the antibiotics for at least 6 weeks, and about 85,000 that were not, okay? So they compared those two particular groups. And what they found was, retrospectively, just looking at diagnosis codes, that upper respiratory tract infections were twofold higher when they looked out at least a year in individuals that received the antibiotics. So there was a big pandemonium, or the antibiotics are causing these upper respiratory tract infections. We just know that epidemiologically that association was there. We don't even know what type of upper respiratory tract problem it was. It was based on a diagnosis code. It wasn't based on, it could have been viral, it could have been bacterial, but this association has been something that people have been noticing, but we don't have any more good data on that I'm aware of. Ted might have some. Okay? So this is the way I think about it. We have patients that have rosacea, we have patients that have acne, and we prescribe them an antibiotic. Okay? And so now they colonize the oropharynx with group A beta hemolytic strep. I'm not saying we're doing anything wrong. We're following the standards that we use to treat these diseases that are still in the literature as the standard of care and in the guidelines. But this is something that's happening as a collateral damage. So now that individual goes and they're hanging around their kid or their nephew or their niece, or they're going to visit grandma, and they cough. And now that organism's passed on to the other person. It happens. Now, does that mean it's going to lead to an infection in another person? I don't know. But the possibility is there, and the transfer of the resistant microorganisms is occurring. And that's the best that I can say at this time point. So we have to be aware of that potential. Okay. The second response is, it is different when you are with the patient. So this is what one doctor said to me. It's easy to tell doctors what they should do with patients when you sit in an office or a meeting room and you are not responsible for the care of the patient. And this is absolutely true. So you think about not only us, but you think about a practitioner that has patients coming in coughing and hacking in the winter, or a kid with a hot ear, and they're thinking, well, it's probably viral, but maybe I better give them an antibiotic, and they can't necessarily get a quick diagnostic test. It's not so easy when you're with the patient. So how do you know which one? When they say 50% didn't need the antibiotic or more, how do you know which ones did and which ones didn't? So that, I think, is the difficulty for the clinician, and we have to get better ways to make those distinctions.